Okay, thank you all for coming so early this morning. I'd like to start by thanking Dr. Dunbar and the other organizers of the conference for inviting me to give this talk. So I'm going to talk about how to get blood stem cells to engraft. And specifically, I'm going to start out by talking about what we do now, which has some problems, and then spend most of the time talking about our studies on using an antibody or testing an antibody directed against SCID or CD117, which we think is going to be a platform to replace chemotherapy and radiation as conditioning for transplant in the future. So what does it take to get stem cells to engraft? Well, I think the biology of stem cell engraftment is relatively complex. It's more complex than transplanting solid organs. Like solid organs, and I'm talking about allogeneic transplants now, there's immunologic rejection, and like solid organs, it's T-cell mediated, but it's more complicated as one crosses the major histocompatibility barriers because NK cells become involved. So there's immunologic rejection of allogeneic cells, and then also above and beyond rejection of solid organs that you have to make space. So there's like this non-immune component to be able to get hematopoietic stem cells to engraft. The other thing is that the graft itself, so a hematopoietic graft itself can give advantage or disadvantage in terms of engraftment just based upon the cell content. So I'll talk about these a little bit more. So this is just giving you an example of what we need to do now in order to get engraftment of the hematopoietic stem cells. So of course, as I talked about, there is the immune barrier, and let me just use the pointer here. I'm not used to using the mouse. So the agents that we use are things like cyclophosphamide and fludarabine, the anti-lymphocyte agents, so we do lymphodepletion, or use antibodies such as anti-thymocyte globulin or CAMPAT. Now with regard to the non-immune barrier, and this is where the idea of space comes in, we think about space as being the endogenous hematopoietic stem cells that sit in these specialized niches, and that in order to get a donor cell in to replace the endogenous cells, you have to get them out, and the only ways we know how to do that is with these couple of methods, which is radiation or DNA damaging chemotherapy. So I list them here. So radiation is sort of the tried and true way of being able to make space, but there are other agents like busulfan and melphalan. Those are the biggest two that we use in transplantation. Cyclophosphamide probably has a weaker effect, but mainly it's busulfan and radiation and melphalan. So before I talk about space, and that's what I'm going to spend most of the time talking about, is agents to replace this chemoradiation, I want to talk about the graft itself. So this is the tissue that we as transplanters transplant. It's, heterogeneous mixtures of cells, and as you can see, there is the stem cell. We transplant the stem cells, the downstream progenitors, and the mature cells. So from a bone marrow transplanter's perspective, we only really need the stem cells to engraft, but as clinical transplanters, we transplant the whole tissue. And that's in part because for many of our patients, they have hematologic malignancies, and we want to give them a graft versus tumor effect. But we also know that the more mature cells can facilitate the engraftment of the stem cells. And so if you transplant a stem cell by itself, it's much more difficult, especially in the allogeneic setting. And so we also know in our studies in the mice that in the congenic setting, or sort of the setting of gene therapy, that the more mature cells also help to facilitate the engraftment. So I show the stem cells here. I show their markers. In mouse, we know that you can isolate them by phenotype, and in humans, we can also do isolation by phenotype for the markers CD34 and CD90, and these come up later, which is why I mentioned them here. So now with regard to creating space, so it's been a goal of myself and my colleagues for many years to be able to make safer conditioning regimens, more targeted, not have to use chemotherapy and radiation. And it was actually a graduate student in my colleague Irv Weissman's laboratory whose project it was to see if there was a way we could use antibodies to target the endogenous stem cells and make space. So Anishka Chekovitz went about looking at different targets and eventually settled on SCID or CD117. So what is CD117? Well, CD117 is a receptor for stem cell factor. So I show a stem cell in the niche, and it's interacting with stem cell factor. And stem cell factor, and the interaction between stem cell factor and CD117 confers survival in the niche, proliferation, and helps in the differentiation. So CD117 is a receptor tyrosine kinase. When stem cell factor interacts with CD117, there are a whole cascade of different signaling pathways which are turned on. So what we know in terms of its expression profile is shown here. So we're thinking we're targeting stem cells, but actually when we look at this tool was created by Jun Seita when he was in Irv Weissman's laboratory. And what Jun and his colleagues did was to prospectively isolate stem cells and then the downstream progenitors, as well as cells along the different lineages. So this is just basically showing you a schematic of the hematopoietic tree. So the stem cells here, differentiating down the lymphoid lineage. We're looking at the T cells, the NK cells, and the B cells. Here's the megakaryocytes, erythroid lineage, and the grands and the monocytes here. And so pink means that the gene is highly expressed. And you can see here that SCID, CD117, is not only expressed on stem cells, it's expressed in these downstream progenitors as well. So when we use the antibody, we're targeting this population as well. So now these are the original studies that Anishka did. She published them about 10 years ago. And what she showed is that if you use an antibody against SCID or CD117, a mouse antibody called ACK2, that when you do the in vitro studies, so she plates the stem cells here and cultures them in the presence of stem cell factor, with or without the antibody. In the presence of the ACK2 antibody, you can see that the proliferation is suppressed. She also used another anti-CD117 antibody, 2B8, and that was less effective. And she went on to test in vivo, and these are the in vivo studies below, the ability of this antibody to deplete endogenous stem cells. So as shown in this panel, so if she treats the animals, mice, then these are immunodeficient mice with ACK2, that there's transient depletion. So we're looking at around day 9 and day 16, but then there's rebound around day 23. So it's a transient effect, transiently depletes the stem cells. And what this middle panel is showing is that when you look in the serum, so she measured the serum of mice for the presence of the antibody, because you don't want to introduce, if you're going to put a donor graft in, you don't want to introduce the stem cells in too quickly if the antibody is still hanging around, because it can deplete your donor cells. And so this is day 5, there's still antibody in the serum, and then by day 7 it disappears. So then she transplanted the animals at around day 9. And this again becomes important as we think about using the antibody in the clinical setting. So as you can see, there's engraftment here. This is engraftment of the granulocytes, and that turns out to be a good marker actually for the stem cell engraftment, which she showed. So about that time, I became more involved, and the idea was, well, this looks like a great way to condition people, and so would we be able to use an antibody against human CD117? And so we were going to make the antibody. We knew that there was a mouse anti-human antibody that was available publicly, and then we did a Google search, and the Google search showed that a company had already made an anti-CD117 antibody, humanized, and so that was Amgen. Amgen had taken the human IgG1 backbone and then grafted in the complementarity determining regions of the mouse anti-CD117 antibody. So they had a humanized antibody. Now they had made it for a completely different reason. They made it for an inflammatory disease. And so we started collaborating with them now many years ago to see if this antibody could similarly deplete stem cells. So these are studies now done by Aaron Logan when he was in my laboratory. They're in vitro studies using the Amgen antibody called AMG 191, and as I showed, you put the stem cells in culture, and in the presence of the antibody, you can see that there's suppression of proliferation, so suppression of hematopoiesis, and this is just the visual of the suppression of the colony formation. What Aaron also did was to generate mice that were humanized, so he transplanted human hematopoietic cells into newborn non-SCID animals, and then once they had engrafted with the human cells, Then he tested the antibody to see if we could get depletion of the hematopoietic stem cells, and that's what's shown here. So based upon these data, we were very fortunate to be granted a very large grant from the California Institute of Regenerative Medicine with the idea that we would translate these studies to a human clinical trial. So one of the first things we did was to go back to Amgen and work with them and see if we could test the antibody in a non-human primate model. Now, as I said, Amgen had already made this antibody, and they had tested for the safety in non-human primates. So they had extensive testing, but they hadn't really looked for depletion of hematopoietic cells. They also had done some first-in-human studies, so we knew the antibody was safe. But the purpose of this study was for us to look and see if we actually got depletion of stem cells in non-human primates. And so we did a dose escalation study. There were only 2 animals in each group with a range of 0.1 milligrams per kilogram all the way to 25. And then what we did is we looked at their CBCs, so see if there's peripheral depletion. Now, one of the things we knew from talking with Amgen is that when they did their first-in-human studies, they had seen an effect they did not want to see, like an off-target effect, they thought, which was there was a decrease in the reticulocytes, which is indicative of the fact that the antibody had suppressed hematopoiesis. So we were overjoyed to hear that. So we were looking at that as well. So in this study, we also looked at PK because we wanted to see how long the antibody is going to hang around in the serum. And then we also did bone marrow analyses on day 3, 6, 9, and 20 after we gave the antibody. And we looked by phenotype for depletion of the hematopoietic stem cells in the monkey, and then also assessed by function. So we took the cells out and then we plated them and looked for if we also had functional depletion. Okay, and this is a slide which compresses our monkey data, but I show the raw data because I think this was some of the best data that I'd seen in a very, very long time. I was overjoyed. So what we did was, this is looking at the FACS plots of the 3490 cells in the monkey this is a representative monkey. So the monkey this is pre-infusion of the antibody, and the 3490 cells you can see here. So these are the stem cells. And at this 1 milligram per kilogram dose, we're looking at day 7 and then later. You can see that this window is empty, showing that there was indeed depletion of the hematopoietic stem cells. And then over time, then there is repopulation. So the antibody looked to be effective in depleting endogenous stem cells in the large animal model. And here we've consolidated the data. So at all of the doses tested from 0.1 all the way through to 25 milligrams per kilogram, we did see that there was depletion and then rebound, although at the highest dose, there was persistent suppression. And so we also did the PK studies, and we could see that at the dose up to 1 milligram per kilogram, that the antibody hung around for about a week. And so when we were designing our clinical trial, we chose to go with a range of 0.1 to 1 mg per kilogram. So what we've gone on to do, and with the serum funding, we've gone on to open a clinical trial. So we successfully got our IND last year, and we're recruiting patients for the study. And the patient population that we've targeted to use the antibody in are patients with severe combined immunodeficiency. So severe combined immunodeficiency is an inherited disorder of lymphocytes, and it is uniformly fatal unless the patients undergo transplant by the age of 2, actually, or unless they live in a bubble. And of course, this is the famous bubble boy, David Vetter, who was a patient, the famous patient with SCID. So just to give you a little bit of background, I think because the conditioning, these patients don't make lymphocytes, and because the conditioning is so toxic, they're transplanted as babies. Some centers do not condition the patients. They give them, replete graft, and the grafts are able to not engraft at the stem cell level, but rather at a later stage of lymphocyte development. And so they'll engraft at the early T cell lymphocyte stage, and then give rise to the lymphocytes for, I think, adequate protection. But many of these children, it's inadequate. They don't engraft, and so many don't have B cell function. And so they have poor immune recovery. And there's other centers which do indeed use conditioning, but there are off-target effects of acute toxicities and long-term toxicities. So our trial, the rationale of our trial is shown here. So I think the reason we chose SCID was because, these patients don't have an immune barrier, so we don't have to worry about that. We really just want to worry about we just want to focus on creating space. We know that this is a patient population that could definitely benefit from non-toxic conditioning. And another part of our trial, which I didn't focus on, is that we're actually using CD34, CD90 selected cells as the graft, because these patients are also very susceptible to get the complication of graft versus host disease, which is mediated by T cells. So it's a phase 1-2 dose escalation study using the antibody, and it's an age de-escalation. So we start with children who previously had an unconditioned graft and so have poor immune function. We know that they are immunologically tolerant to their donor, so again, our focus is on just making space and getting the true stem cells to engraft and make a more robust lymphocyte repertoire, including making B cells. And the trial is open to haploidentical as well as unrelated donor transplants. So the objectives are, the primary objectives are safety, tolerability. We're looking at the PK, and we're looking at depletion in the bone marrow. And the secondary objectives are to see if we can get true myeloid engraftment and lymphocyte reconstitution. So, as I said, our trial is open, and we're pretty excited about it. I think that it was a long road to get here, and if I've seen some of you in the audience before, that we are interested in recruiting patients to the study. So please feel free to come and talk to me about that after the symposium. So now that's all well and good. But when we thought about expanding the use of the antibody to the wild type setting, or with individuals with lymphocytes that have intact immune systems and lymphocytes, we realized that the antibody doesn't work well in that setting. And so this is data from Kanka Shabra and Haisuk in my laboratory, where we show that, the depletion is much better if you are T or B cell, NK cell deficient, and is much longer. This is looking at days, but if you're a wild type animal and you're given the antibody, you can see that the depletion is much more shallow and the rebound is much faster. So whereas we can get engraftment at this time point by putting the stem cells in, we've not been able to get engraftment with just the antibody alone. So one of the questions that my postdoc wanted to ask is, well, so why is that? Is it, if we understood the mechanism better by which the antibody worked, then perhaps we could potentiate its effect. So what Akanksha did with Kip Weisskopf and Aaron Ring was to generate antibody, so to make FAB fragments from the antibody, so separating the antibody from the effector end and just isolating the binding end. So the question being, is it the interaction between KIT and its ligand, or CD117 and its ligand, that gives it the effect? Or do you need the effector function of the antibody? So the studies that she did are shown here. She tested the antibody at decreasing doses compared to the FAB fragments, and showed that whereas the antibody was still active at a fairly low dose, when you gave large doses of the FAB fragments, so blocking the binding, there was no effect in vivo. And also when she looked in a different way at FC receptor deficient animals, so they can't bind the effector end of the antibody, she got the same result, suggesting that you really need the effector function of the antibody in order to get good depletion. So we happen to be working with a laboratory next to us, Ravi Majeti and Irv Weissman, who had been potentiating the effect of macrophages in the clearance of target cells. And so this is looking at the interaction between SIRP alpha and CD47. And for those of you who are not familiar with this, so CD47 is expressed on a number of cells, including cancer cells. And what CD47 does is it transmits a negative signal to the macrophage, so not to be phagocytosed by the macrophage. It's the don't eat me signal. So if you can imagine, if we're targeting stem cells, we have an antibody that can make it vulnerable to macrophage or to phagocytosis, but the stem cells express CD47, so then it can suppress the phagocytosis by the macrophage. And so we thought as well, maybe if we did a synergistic study where we looked at 47, the anti-47 agents in combination with 117, could we get better clearance of the endogenous stem cells? And in fact, we did. So this is the slide I showed you looking at the depletion of stem cells in the immune deficient animals, the depletion of stem cells in the wild type, but then when we add 47, so now we're using the anti-CKIT or the anti-CD117 antibody in combination with 47. So here's the antibody alone, here's the 47, but the two together gives you very deep depletion, again, looking like the wild type. I'm sorry, looking like the immune deficient animals. And this is looking at the bone marrow, picture's worth 1,000 words, looking at the bone marrow where the antibody alone is used, the ACK2. And this is looking at the combination, and you can see that there is really a profound difference. And indeed, we know that in these animals, the depletion was so profound that we had to rescue them with transfusions, but eventually they rebounded. So now it's one thing to look at depletion, but could we get engraftment? And that's what's shown here. So now this is looking at the anti-CD117 antibody with a reagent that blocks the interaction in SIRP alpha antagonist. And again, looking at engraftment of the stem cells in the congenic setting. So this is the setting which is analogous to a gene therapy setting. So it's just there's a 1 allele difference, it's a 45 allele difference, and so we use the antibody alone or the antibody in combination with 47. And you can see that we get robust engraftment in the granulocyte lineage as well as the lymphocyte lineage. So we think that this is proof of concept that we could get robust engraftment using just this combination alone for gene therapy. And then our last data slide I'm going to show you is, of course, we want to see, will this work if you're crossing allogeneic barriers, because it's been our goal that we're going to be able to use an all-antibody regimen eventually. So what Akanksha, Kip, and Aaron did was to now transplant across allogeneic barrier. These are actually MHC-matched animals. They use the anti-CD117 antibody first, and then use the CD47, the anti-CD47 antibody, and then transplanted in the pure stem cells, so the naked stem cells, and then also did a regimen using anti-T cell antibodies to suppress the immune rejection. And this is kind of a busy slide, but what it really captures is it's the combination of the three which allowed robust engraftment long-term. And for the reviewers, we had to show that we have a stable engraftment beyond, I think it was 20 weeks. So to summarize, the monoclonal antibodies that target CD117 can create hematopoietic stem cell niche space and have the potential to replace chemoradiation. The clinical trial is now open, which tests if an anti-CD117 antibody can effectively condition SCID patients transplanted with 3490 purified allogeneic stem cells. The combination of anti-47 potentiates the niche-clearing effect of the anti-CD117 antibodies. Combined anti-CD117 plus anti-CD47 allows robust engraftment of congenic stem cells in immune-competent mice. And anti-CD117 and anti-CD47 plus anti-T cell antibodies permit stable engraftment of allogeneic stem cells in immune-competent mice. So just again, the future as we imagine it now is not to give radiation and chemotherapy, or even, we didn't really talk about graft versus host disease, but to give purified cells in patients that receive antibody conditioning. So I'd like to close by thanking the many people involved in this study. So first of all, I want to point out the people in my laboratory. So Akanksha, working with Kip and Aaron, did the combined CD117 and 47 studies, also with PJ Schnorr. And Haisuk Kwan, together with members of my laboratory, were champions of the non-human primate studies. I want to recognize the clinical team who has been involved in this clinical trial. Again, it's been a long haul. Rajni Agarwal is the PI at Stanford, and Chris Dvorak and Mort Cowan are the PIs at UCSF for the SCID study, and Maria Grazia is the medical director of the study. And then acknowledge my team, Susie Prohaska, Ann Lay, and Alyssa Gutman, and also thank all of the collaborators who have been involved. Thank CIRM for their funding, and also thank Amgen for being such a good partner with us. And thank you all again for coming so early to this talk.
Open for presentation. All right, questions?
Yes.
Hi, I'm Umuk Choi from NIH. Thank you for a great presentation. In my memory, the brain has a lot of SCID expression too. In your monkey study, did you see any side effect or some toxicity of antibody application?
Yeah, in the mouse studies, we have not seen the side effects and any kind of complications neurologically. And also, the Amgen did do quite a bit of testing at very high doses in the non-human primate, and they did not report any effects in the brain in terms of neurologic toxicity. Yeah.
Okay, thank you.
Cindy Dunbar, NIH. Do you have any better hypotheses or any more information about, why you have to block CD47 axis specifically in immunocompetent individuals or mice to get engraftment? Because are macrophages just more turned on in SCID settings? It isn't sort of intuitively obvious to explain that finding.
Yeah, I think that there's two issues. One is like when we actually have gone back and looked in wild type animals, it's like, what's the problem? And we know that it's not really the macrophages. We haven't looked at that per se. It's the presence of T cells. So I'm not, so that's one thing. But we just took advantage of the fact that we could potentiate the effect of macrophages by using them in combination. So kind of the mechanism of why wild-type animals are more difficult to use the naked antibody in is one thing. But then just think that if we use the 47 reagent with this particular reagent, we just get a synergistic effect.
So it's interesting to try to figure out why.
Yeah, right, yes.
Recently, I read a paper about valine deficiency in the diet, which causes damage to hematopoietic stem cells. And I'm wondering if you could comment on a comparison between the two in terms of efficacy and also in terms of safety for wild-type transplantation.
Yeah, actually, it was a colleague in the next down the hall from me that did those studies. It would be great if that could work in this setting, just like a transient deprivation of an amino acid. But in those studies, I think that they're very interesting. I do know that they used grafts that are replete with all of the populations, and maybe they get a facilitating effect. I'm not sure that it would be as robust using pure stem cells, where you have to, it's difficult to overcome the barrier to engraftment. But that said, I did have someone in my clinic who was not eating very well, and I showed him this paper, and he got motivated to eat more, and it is actually his numbers got better. His numbers were tanking, and they actually got better, so I don't know, I used it to my advantage in that situation. Yeah.
In your study, how long do you have white cell depletion to the extent that the patients are at risk for infection?
So in this particular, this particular combination, the white cells are not so affected. And we know that in the studies that were done with the humanized antibody and where they were given at pretty high doses, there was really not that much of a drop in the neutrophils. It's really like the red cell lineage, because CD117 is expressed along the lineage, I think, to a much higher degree. So it's the red cell lineage that's affected and not so much the white cell lineage.
So is this methodology ready for prime time?
Well, we're in clinical trials, so I think that part of it is, but the combination, I think we're going to have to still work out those preclinical steps, but hopefully prime time will be soon.
Thank you very much.
Yeah, thank you.
So it's known that the glycosylation profile, the constant region of the antibody heavy chains, could impact the binding to different FC receptors. I was curious if you'd had tried using defucosylated or modified glycosylation profile antibodies.
Yeah, that's a really good point. We haven't modified that, and not the humanized. The humanized antibody, you probably noted, was deglycosylated, right, in a critical residue. But still, it seems that the idea was to be able to have the antibody hang around longer. We haven't gone back to modify that product at all to see. Yeah, but that's, maybe the next generation.
Thank you.
Yeah.
I think we have time for one more question.
What kind of chimerism are you looking for?
It depends upon the disease. I think that probably the gene therapist can answer that better than me. I think, in terms of, what it takes to correct sickle cell or thalassemia or, even SCID itself. I think that, I think we can get mixed chimerism. That's my understanding. But in terms of, in a cancer setting, of course, we're looking to convert people fully over to donor type. So I think that the antibody alone and these antibodies alone may need a little extra help.
Yeah, certainly. But in your mice, what did you see?
In our mice, we're looking for, what we really want, what I want, is actually stable chimerism. And I think that if you can get stable hematopoietic chimerism, you can cure a lot of malignant disorders. But also, we've shown that you can get tolerance induction. So you can treat autoimmune diseases, and you can also, do co-transplants of organs. Yeah. Great. Thank you very much.
Okay. I want to thank the organizers for inviting me, and I'm delighted to be following two outstanding speakers and who sort of set the stage. So we've heard about ways of inducing clearing of the marrow. That is a kind of conditioning without using chemotherapy or radiation. And then we've heard about some novel ways in which cells find their way back to the marrow and may have important implications, perhaps in combination with these two approaches. Today, what I'd like to do is to follow this up with a more sort of, I would call it an empiric talk. That is to say, okay, if you have these kinds of things, why does this all matter, particularly in the gene therapy setting? So, no conflicts. So what we should be thinking about today are three things. The kind of vector we use, no conditioning versus various kinds of conditioning. Although, as I put the talk together, I realized that I have something to say about age of the recipient as well when looking at the empiric outcomes of gene therapy. So what I'd like to do is start with just a brief review of some seminal clinical trial outcome results demonstrating some key principles relating to these topics. So in 2002 and 2004, we had a tremendous breakthrough in the use of ex vivo murine gamma retrovirus vector gene therapy without any conditioning, and that was shown to restore immunity to infants with XSCID, but long-term follow-up of these patients shows that it does not result in long-term marking of B, NK, or myeloid cells since there was no conditioning. In 2002, Audi and colleagues and Gaspar and colleagues, after many attempts to make gene therapy work in ADA SCID, using an approach that worked without conditioning in XSCID, found that if they used low-dose conditioning, they were able to get this to work and achieve multilineage marking with restoration of immunity to infants, but only if the low-dose busulfan is used. And then I mentioned Dr. Biffy's paper and Dr. Cartier's papers because what they found is that to get what they needed done for leukodystrophies, they needed to use very high levels of of chemotherapy because they needed to deliver an enzyme at probably super pharmacologic levels. So you have various reasons to use different levels of conditioning to achieve the goals that you want. So today I'm going to talk about two gene therapy examples that we've been involved in, and I'm going to provide some back history forward to show you, I think, some principles that about conditioning that are important, and perhaps even about vector choice as well. So it's, in talking about chronic granulomatous disease, it's important to note that this is an immune deficiency in which we know there's no selective growth or survival advantage to correction of the defect. We know that because female carriers are phenotypic mosaics, and whatever they are in childhood, 10% normal, 90% abnormal, or 90% normal, 10% abnormal, they hold that for life. When they get in their 60s and 70s, sometimes there's some drift one way or the other, but mostly this is pretty stable. So it says having oxidase normal neutrophils and monocytes doesn't at all influence sort of lifelong survival of the stem cells that are working off one or another X chromosome. We also know from a paper that the NIH group published in 2010 that even in CGD patients, if you look at the residual amount of superoxide, whatever it is, there's a high correlation with survival, with long-term survival. So it suggests that any level of correction that you can increase this matters. Just to remind you what CGD is, it's a defect in the phagocyte oxidase. Patients get recurrent infections and granulomatous inflammation. There are 5 forms of this. And today I'll mostly talk about the X-linked form, but there's also a common autosomal recessive form that I'll be referring to early in the talk and then move on from there. So just to remind you what this is, in the resting neutrophil, this is a multi-subunit enzyme. Some things exist in vesicles, some things exist in the cytoplasm, and when the cell's activated and encounters a microorganism in the presence of oxygen, all these things come together at the phagosome, and electrons flow from NADPH to oxygen to make superoxide, and then within the cell this is converted to hydrogen peroxide and hypochlorous acid, which are all work to protect the host. So I also need to introduce you to sort of 2 diagnostic tests that are standard for CGD. One is the DHR assay, which is a flow cytometry assay, and when cells produce oxidants, neutrophils become highly fluorescent. There's also the old classic nitroblue tetrazolium dye assay for those of you who don't believe anything unless you look in a microscope and see what the cells look like. So I want to bring you back 20 years to a trial that we ran using gamma retroviral vector, but without any conditioning. I think the outcomes of this trial, which we didn't really fix the patients very well, but in retrospect, we learned a lot, and I think we even learn more now based on, you'll see the progression of things as we go along. So just to show you that using the looking through the microscope, yes, patients ended up with circulating neutrophils at very low level. How low? Well, if we look at this at the peak, it was 1 in 1,000 cells, and it was very transient. It appeared, this is without conditioning, with the gamma retroviral gene therapy, and it came, it rose to 1 in 1,000 cells, and it left. So now we move forward to the mid-2000s and a study using a SFFE vector by Ott et al. And others. They were able to demonstrate with submyeloablative busulfan conditioning that they could get gene-corrected cells in. There was an issue with the SFFE vector that was augmented insertional activation. What it basically converted a disease in which there's no selective advantage to a genotoxicity event that actually gave those cells a selective outgrowth advantage. In our study, which was done about the same time using the MFGS vector, we got quite different results in the sense that we got early marking that was quite high, and then it went down. So we didn't have any genotoxicity. But what happened long term? What happened was that it went down, and by about a year out, one of the patients was at 0.5%. The other was even much lower than that. But this was stable out to 7 or 8 years. So we went from 1997, where we did basically the same thing and didn't get any engraftment, and now we did conditioning and we got engraftment, but it was pretty low. That is, as it went out. But we did get engraftment. So the conditioning changed things from no engraftment at all over the long term to engraftment out at many, many years. But the vector itself probably wasn't up to the task. And you can see that out even at 7 years in this patient, he was still about 0.5% oxidase positive and GP91 positive cells. Now these patients, that was not a fix of CGD, and eventually these patients were transplanted. So more recently, Thrasher, Gretz, and et al. Developed an interesting vector, which you can read in the slide, and that vector now has been used in a non-randomized multi-center trial that's been open in the US and in Europe. And I'm not going to go through all the details of this trial because I'm using the early results in the trial as an illustration rather than giving you, highly detailed outcome. I will say that the patients got apheresed, cells were collected, they were transduced. While they were being transduced, the patient gets busulfan conditioning, and then cells are infused in the patient. So the first young adult patient has been treated at Boston Children's Hospital and is doing well at 18 months. We did the second patient in the study in the US, that patient was treated in July 2016, that's an error. He's now about 9 months out, and then at Children's Hospital in LA, a third patient is early after treatment. In addition to the US patients have been treated in London and Paris with this vector, and really the data trend in all of the patients is surprisingly similar. And so I'm just going to use the US patient as an example. This was an 18-year-old male, had a lot of problems with infections, received a good dose of cells at a good vector copy number, and there were no adverse events. Of course, he had cytopenia and some mucositis, but actually you can see he was discharged at day 20. So, and that's been sort of the experience so far. So this is his this is not his. This is a normal DHR assay, just to show you unstimulated at the top, stimulated at the bottom. So if we had 100% fix, this is what we'd want things to look like. In this patient, we ended up with about, at 1 month out, at about 28-29% oxidase positive cells. The obligate DHR assay, so that if you don't believe flow, you can see it with your eyes. And GP91 is expressed not at fully normal levels, but a little bit less in the cells. But despite that, the actual amount of superoxide is quite good, and the patient has remained stable in the high 20s % range. The lineage marking is what one would expect, a little bit higher than the actual correction. And so what do we conclude from this? That lentivector gene therapy with submyeloablative busulfan conditioning is well tolerated. You get stable correction of oxidase activity, and this is now over the whole group of patients treated in the U.S. and Europe so far, about 20 to 40%. In those patients who are out far enough, it's stable to 9 to 18 months. Not presented is that the average superoxide production per corrected neutrophil was in the lower end of normal, but well in a range that I think is beneficial to the patient. So what do we conclude? Conditioning is absolutely necessary for sustained gene marking, and lentivector is required for the high levels of prolonged marking and functional correction of myeloid cells. So I'm going to use as a second example our study of older children and young adults with X-linked severe combined immune deficiency who have persistent defects and clinical problems despite one or more parental lymphocyte-depleted haplotransplants as infants. This is, in fact, one of the patient groups that Dr. Shizuru is hoping to recruit to her study. And what I'm hoping is that we can get together at some point and combine these things, as you'll see. I'll move quickly through this. XSCID is T negative, B positive, NK negative. They occurs from mutations in the IL-2R G gene. And in infancy, people need a transplant quickly. And what's usually only available is a parental haplotransplant without conditioning. Some centers use some conditioning, but most centers don't use any conditioning. However, there's the problem with that is that there's often just a pure T-cell donor graft. As patients age, they get progressive decrease in donor function. They need lifelong IgG. They make little IgM or none. They get recurrent and chronic infections. Most of our patients referred to us have persistent norovirus infection. In fact, it's the odd one that doesn't have a persistent norovirus infection, and that causes a lot of morbidity in these patients. And then there's other things. I won't read them all. So just to go back to those original studies, leaving aside any discussion today of genotoxicity, if you look at this, 26 out of 29 patients who received gamma retrovirus vector without marrow conditioning benefited long-term from gene transfer, and there was robust T-cell number and function, but as I said earlier, there was no long-term gene marking of B or NK cells, and that's a critical issue here. So inspired by those successes in the infants, both Adrian Thrasher in one study and us at NIH in another study tried to do this in older patients. Bottom line is, and I'll just read the bottom thing, the same gene therapy approach that worked to restore functional gene marked T cells in infants without conditioning did not work in older children. That is, most of them, of course, also had a haplo donor graft that was competing. So the combination of things is this just didn't do anything for these patients without any marrow conditioning. So there's a clinical trial open at the NIH for older children. I want to make a plug for the fact that there's a trial open for newly diagnosed infants using the same vector at the centers listed below. And I must say, I'm not going to talk at all because it's not my data about the outcomes in the infants, but the early studies look like infants do even better than anything I'm finding in my older patients. And I need to say that so I get to this age issue as well. So this is the trial. It's a lentivector. Those are some of the background papers, and this is the first trial use of lentivector to treat XSCID, and also the first to use busulfan conditioning for XSCID. This is a more detailed look at what we did. It's very similar, in fact, to the scheme I showed for CGD, except that the amount of busulfan is significantly lower that we're using, and you can see the AUC targets that we're aiming for. we've treated a series of 8 patients. Dr. Suksi Duravan in our group reported early studies, not in 2018, but in 2016, in Science Translational Medicine, and so you can get a lot of the more detailed background about this by looking at that paper. I just, because I don't have a lot of time, I just want to show you that we're getting really good marking, super outstanding marking in some of the patients in myeloid B and T cells, a little lower marking and slower to come in some other patients, but it's, we expect variability, and the titers of some of the vector we used varied as well. But the important thing is that one thing we learned from looking at subject 1, who's now out at 4 years, is that wherever we were early on, it just keeps getting better. And that was a big surprise to us, and we're seeing that in the other patients as well. So in this case, the use of conditioning and the Lentivector and a touch of patience really is very helpful here. And now I'm just going to quickly run through to show you that vector copy number in all of the patients looks pretty good in the various lineages. So this patient 2, 3, 4, 5, 6, 7, and 8. Again, I don't want to dwell on it, but the important thing is that everybody has myeloid marking. Everybody has T cell marking, and everybody has increasing B cell marking and quite substantially increasing NK cell marking. This is just for those of you who ask, are we making naive T cells? This is the sort of the markers used to look at naive T cells, and you can see in patients, I don't show patients 1 and 2, but 3, 4, 5, and 6 are all coming up. And again, this theme of it just keeps getting better. So summary and conclusions is that safe Lentivector gene therapy with busulfan conditioning for older XSCID patients is safe and well tolerated. We're getting persistent multilineage gene marking in all 8 patients. For those of you who ask, is this benefiting them clinically? Well, 5 of the 7 who had norovirus for years and years and were sick with it no longer have norovirus. If that's all we did, that would be a big change in their lifestyle. But there's improved cellular and humoral immunity. Some patients have achieved supplemental IgG independence and protective titers to immunization. And the first 6 patients significantly reduced IgG requirements and now make normal levels of IgM. So early results in the trials with infants using the same vector and with busulfan conditioning are showing, I should not say similar, better robust marking of B and NK cell lineages, and of course they have no competing donor T cell compartment, and so those are coming in quite robustly as well. So the final conclusion is that as a general rule, anything done in infants exceeds the outcome in older children and adults. So there's something about stem cells and ability to transduce and all sorts of things, I think that I didn't cover today because this is an empiric talk, not a hard science talk. Lentiviruses seem to transduce human very long-term, permanently repopulating stem cells better than gamma retroviral vectors. That doesn't mean that gamma retroviral vectors aren't useful, important for other kinds of uses, but if you want to get it into the long-term repopulating stem cells, lentivectors seem to be better. For some immune disorders with very strong growth advantage for certain lineages, such as our older patients, such as the infants, sustained repopulation of that lineage may occur without conditioning. But for primary immune deficiencies, hemoglobinopathies, and leukodystrophies, some to high levels of conditioning are required. And even in PIDs with very strong growth advantage, such as our older patients with XSCID, sustained marking and correction of other lineages requires conditioning. And it says this is about the SCID gene therapy, but in the Laboratory of Host Defenses column and some of the other NIH people, they were also critically important in the gene therapy of CGD at NIH. I want to particularly mention Dr. Sukhsi Duraven, who really is the PI for the XSCID study, and Elizabeth Kang, who's the PI for the CGD, XCGD study. And thank you very much. Thank you.
This presentation is open for questions now. I guess you were very clear.
Okay. Thank you all.
So, okay, so I would really like to thank all the three speakers for... I'm sorry.
Sorry.
Yes.
Juan has a question. I'm sorry.
Okay. Thank you.
I was just waiting for the audience, but if there are no questions. Well, I can imagine that deciding the conditioning for those diseases where there is no proliferation advantage on the corrected cells could be challenging. And I wonder that, well, particularly, this may generate the non-stable presence of the gene-corrected cells in the body, and also one could presume the possibility of having some immune reaction against the transgene. So I wonder to what extent any of these issues have been a problem in the gene therapy of the diseases you have mentioned.
So we're probably not going to run into trouble with focusing on your last issue. We're probably not going to run into troubles with immune rejection in the XSCID patients. For CGD, you're correct. There's at least a theoretical possibility that we may come across a patient who has antibodies already or could develop a T-cell reaction to the neoantigen. So far in all the studies in Europe and the US, that has not been encountered, but it's certainly theoretically possible.
And with respect to the stability of the corrected cells, when non-myeloablative conditioning is used, is this very variable, much variable as compared to a myeloablative conditioning? Does this imply some risks that at a certain times numbers of corrected cells in peripheral blood?
So most of the time when centers are using very low or modest levels of conditioning, it's because people don't want to give anybody, let alone small children, busulfan in large amounts. If the people working on serotherapies for this can make it work really, really well, then you're right. Why not get close to ablative levels with gene therapy, and we'd probably get a better outcome all around. But you know, safety of the patient and sort of balancing all this is, you know, leads those of us who are treating some sets of these patients to use lower levels. And of course, for the leukodystrophies or for CGD, you know, people just have to go higher. They're not going to get clinical benefit from this, and you don't want to put people through this unless you have a shot at clinical benefit.
Any more questions? Yeah.
Yes, I'll be brave enough to ask a question. Actually, I have two questions. One is that both conceptually and experimentally, there is an interrelationship between not just the intensity or the dosing of the conditioning regimen, but also the dosing of the stem cells that are being infused. So my question is whether you've looked also at the outcome with regards to the dosing of the CD34 cells, as I noticed that in some of the patient trials, the range can be quite large. And I wanted to know what the outcome would be if you also analyzed the dosing of the CD34 positive cells. And the other question is, as you're also considering the reduction in the dose of busulfan, and acknowledging, of course, that you are very much minimizing the toxicity of the regimen, what concerns there are, what clinical evidence there is with regards to the enhanced risk of the genotoxicity, since you are allowing a number of the cells to survive after busulfan exposure. And what is the clinical data? Perhaps is perhaps premature at this moment. What is the long-term risks of carcinogenesis from the busulfan exposure?
So that was actually 3 questions, but I'll see if I can remember them. So long-term carcinogenesis, there's no question that alkylating agents and radiation therapy, I haven't done such studies, but there are huge, many studies in the literature showing that there is a long-term cancer risk. Above and beyond that, there are some immediate risks for some patients with use of busulfan, and these are organ toxicities in addition to the toxicities that are expected from the drug, such as the cytopenias that then hopefully come back after you've transplanted the patient. You then asked about overall risks and things, when running a clinical trial, one has to tailor the risk profile and what you do to the likely sickest patient you're going to be treating in a clinical trial, because you can't run a clinical trial where you say, well, this is a really healthy guy, I'm going to give him a lot of busulfan. This is someone who comes with a lot of bronchiectasis and other kinds of problems, and I'm going to give him a lower dose of busulfan. You can't do that. So you have to do your clinical trial adjusting the risk profile to your likely highest risk patient. And then you had remind me of your first question. Just a few words.
Was that my second, first, or third?
No. The very first,
my first question
the very
was
first
actually,
thing that you
my
asked.
first question was related to the interrelationship between the
Yes,
conditioning
okay.
and the dose of your CD34.
Exactly. So I'm going to dodge and weave and hedge on that, because what I can tell you is that we and many others whose data I've seen presented have tried to make strong correlations between dosing of cells that you give, and also the AUC of the busulfan and so on. And all I can say is that that when you're trying to get your busulfan in a particular place, there's a relatively weak, and then it gets stronger as there's big difference in the AUC that a patient gets with busulfan. So that affects. So there's a lot of talk about targeting. We're now targeting for most of the things that we're doing, but understand that targeting says you actually know what you ought to be giving the patient, and that's still very controversial. How much should you give is a separate question from can you give a specific dose. So that's my first dodge. The other is that we've been finding that cell number matters some, and others have too. So if you really something goes wrong and you just don't have enough cells for a patient, I've seen in other studies, those are the patients who don't engraft well, who don't do well, and so on. So big difference in cell numbers matter. But I think one of the biggest things is the titer of the vector. And when I say titer, I'm talking about effective titer. That is, you get your vector and it's actually transducing long-term repopulating cells at a higher amount versus a lower amount. Everything else being equal, that makes a big difference, and we've seen that in our study. I think with some dodging and weaving, I think I've answered your questions. Thank you.
Well, thank you again.